Hello everyone, I am Anupam here and today we will discuss about COVID associated mucormycosis, otherwise called as CAM, unpopularly or popularly called as black fungus infection, which is a misnomer we will discuss today. So let us go straight into it. Right. So COVID associated mucormycosis, otherwise called also CAM, happens to whom? Right? To patient who has moderate to severe COVID-19 infection, especially patient who has got hospitalized, right, and has received either steroids or other immunomodulator that we use in COVID, for example baricitinib or tocilizumab, etc. Right? These are the patient who has the risk factor to develop COVID associated mucormycosis. Plus, what are the other significant risk factors? Uncontrolled diabetes mellitus type 2 or patient having active DKA or hematopoietic or stem cell transplantation or CKD patient on iron chelators or patients who are receiving iron supplement or iron chelators, right? Especially we will target in our COVID patients who have uncontrolled diabetes mellitus type 2 or DKA. It is these patients when they acquire infection of COVID-19, then they get hospitalized, get steroid and other immunomodulators, they are at highest risk of developing mucormycosis, right? So these are the risk factors. Why iron is so important? So we want to remember here one point. Iron helps in fungal growth, especially mucormycosis, right? And what happens in DKA? There is increase in serum free iron. Plus, when you use iron, it will directly stimulate the growth of fungus. When you use iron chelators like deferoxamine, what they do, they act as what we call as siderophores, right? What does it mean? That means they carry the iron from outside to inside of fungus. So these iron chelators, they act as siderophores, carrying the iron from outside to inside of the fungus and help them grow. So this is very, very important, you have to remember. So you have to prevent decay or treat decay. Do not give iron to this patient and avoid chelators, right? Then how they present? Second question, how they present? We will discuss about the symptom and signs, but before that, when they present, right? When they present, they can present to any COVID infected patients during the active stage of infection, when the patient is ongoing treatment, or patient has recovered. It can happen to them also, or it can happen post discharge also. So you have to be very, very careful, right? How they present, this is very, very important to find out what my patient can have as symptoms or signs. So we have two kinds of disease manifestation. One is called rhino or cerebral mucormycosis, right? So rhino or cerebral mucor, right? And you can also have what you call as pulmonary mucormycosis, right? So how they present? So in the ROCM, it can present as number one, pain, most common side effect in this patient. So whenever your patient has pain, for example facial pain, toothache, or headaches, or vital pain, right? Any kind of pain in your COVID patient should make you suspicion of developing a mucormycosis. Number two, it can have black or muddy brown discharge from nose, right? This is very, very important. Third, it can have blurring of vision or diplopia. Fourth, it can have black scars in the skin. This develops how we'll discuss, right? So in pulmonary mucor, the symptoms will be cough, chest pain, dyspnea, pleural effusion, hemoptysis, right? And in both these, there will be fever. So we have to be very suspicious when a COVID patient, initially they recovered and there was no fever. Now they have fever with any of the signs and symptoms, right? So we have to be very suspicious about diagnosing COVID related mucormycosis, right? Now how to diagnose? So diagnosis, you have to remember, as a rule of thumb, this CAM is a medical or surgical emergency, absolute emergency. You have to treat it immediately. So whenever you suspect mucormycosis, you have to start managing, and also at the same time you have to diagnose. How to diagnose it? For ROCM, we can do MRI PNS and MRI brain with contrast, and also for pulmonary mucormycosis we have to do a HRCT chest. But typically you will find a reverse halo sign. What is reverse halo sign? GGO surrounded by consolidation. This is opposite of halo sign. Halo sign, there is consolidation which is surrounded by a GGO, and it happens due to extensive angioedema, right? What happens in COVID patient actually, extensive angioedema will cause thrombus formation in the vessels, right? Then it will do necrosis and produce black scars, especially in the skin, right? That we have discussed here, black scars. Also in the lung, when it produces necrosis, it produces halocine and also reverse halocine, right? So this is the mechanism how it produces the typical CT features. So this is one, imaging, right? First diagnostic modality is imaging. Second is, number 2 is histopathology and microscopy. In histopathology and microscopy, you will find these are septate, broad, irregular, branched at 90-degree organisms or fungus. These are all characteristics of hyphae, right? Number 3 is, if you can have a bile specimen, bronchoalveolar lavage specimen, or if you cannot obtain it, you can have something called mini valve or tracheal secretion. Once you have it, then you can have a histopathology and microscopy, right? Number 4, these patients should typically be not having serum galactomannan or serum beta D glucan. Both should be negative, because typically the mucormycosis wall do not contain these two components, right? So in a patient, if you are suspecting mucormycosis and they're also positive to these components, that means your patient is having something other than mucormycosis or something including mucormycosis. That you have to be very, very careful, right? Now coming to the treatment. Treatment is 3 types. Number 1 will be reduction of risk factors, right? This is very, very important. For example, if your patient developing DKA, so treat DKA very, very strictly. Control diabetes mellitus type 2 so that it does not go to DKA or uncontrolled hyperglycemia. So always religiously treat diabetes patients. Number 3, decrease steroids or immunomodulators, and if possible stop them, right? This is very, very important. Number 4, do not give iron supplements or chelators, right? Second treatment will be surgical. This is very, very important. In the imaging, if you found the disease is extensive, then you have to debride it. There is no other option, right? So debridement, and when you debride, we can send the tissue for HPE, that will confirm our diagnosis, right? And sometimes you may have to exenterate eyes if it is involved extensively, or lobectomy in the lobe if the lungs are involved very badly, right? Surgical. So always this kind of patient will get a surgical opinion, right? Number 3 treatment will be antifungals. So we have Number one drug, that is liposomal amphotericin B, is the drug of choice. Also, we can use deoxycholate amphotericin B in a resource or cost limited settings, right? What is the dose of amphotericin B liposomal? That is 5 milligram per kg per day, dissolved in 200 ml of 5% dextrose, given over 2 hours. If brain is involved in that situation, so brain involvement by mucormycosis, increase the dose to 10 milligram per kg per day, right? For deoxycholate, the dose will be 1 milligram per kg per day, and this has to be given about 4 to 6 hours to prevent infusion reactions, right? So amphotericin B should be given in initial phase. Then you can do what you call as re-imaging and re-HPE, histopathology. This has to be given for 4 to 6 weeks. If it's improving, then you can start, that is what is called as consolidation phase, and in that phase you can use posaconazole tablets or injection or isovuconazole tablets, right? So treatment is three-pronged: reduction of risk factor, surgical treatment, and antifungals, right? Then how to prevent it? This is very, very important. How to prevent CAM or COVID associated mucormycosis? The number one point is control your diabetes mellitus type 2. Number two is steroid. Limit its use. Only use in indicated patients. Indicated patients only. Only use in indicated patients. Who are the indicated patients? More than 7 days of COVID-19 infection plus respiratory support. Patient must be recovering oxygen. Only to those patients only you can give steroid, dexamethasone, plus give low doses, right, like 8 milligram per day, right? And number three, do not prolong treatment with steroid. Apart from other infection, it can cause mucormycosis. So less than equal to 10 days, that's all. You have to stop it at that time, right? And limit iron use from outside. Do not use chelators, right? These are something we have to do to prevent CAM. Also you have to use mask, because this organism is ubiquitous. It is present everywhere. So you can use a mask to prevent yourself for getting exposed, right? Now we have to clear some misconception. This is not black fungus. Black fungus is something else. This is a misnomer for COVID associated mucormycosis that is now rampantly being propagated in the media as black fungus. This is not black fungus, but this is a dangerous fungal infection to happen to any individual. So we have to be very, very careful, and this is not contagious, right? So this is not contagious and does not require prophylaxis. So do not give antifungal to each and every COVID-19 infected patient, because it does not require prophylaxis, and a very less percentage of population will get this infection. So you cannot use rampantly antifungal agents as prophylactic agents, right? So today we discuss about COVID associated mucormycosis infection and how it happens, what are the risk factors, how they presents, how to diagnose it based on different kind of modalities, and how to manage it. You can see it requires a surgeon, a ENT specialist, intensivist, microbiologist. So it's a multidisciplinary approach. So whenever you suspect a patient having mucormycosis, call all the people and start treatment immediately. Of course, you have to prevent from happening it to our near and dear ones. So we have to control the diabetes of our patient. We have to limit the use of steroid in our COVID patients. I will meet you in next class. Thank you very much.